Lesson 7 will help us define illiteracy in the adult population, assess the impact of low literacy on motivation and compliance with healthcare regimens, and design teaching strategies and educational materials to assist those with low literacy skills. Literacy is the ability of adults to read, write, and comprehend information at the 8th grade level, and illiteracy, the ability of adults to read, write, and comprehend information at the 4th grade level or below, and low literacy, the ability to read, write, and comprehend at a 5th to 8th grade level. Literacy, as it relates to health, is defined as the ability to read, interpret, and comprehend health information to obtain wellness. Functional illiteracy, the lack of reading, writing, or comprehension skills needed to function in society, and readability, the ease at which written or printed information can be read. Comprehension means the degree to which individuals understand and interpret what they have read. Numeracy, the ability to read and interpret numbers. And reading, the ability to transform letters into words and pronounce them correctly. Illness, medication, and treatments can cause stress and anxiety that interfere with comprehension. Oral literacy must also be considered as certain phrases and slang may interfere with comprehension. Computer literacy is also important as much information is communicated and accessed in the healthcare setting via computer. Telecommunication requires the clinician to assess computer literacy of the patient, as many tools are available to help the patient learn about their disease, access, manage, and store their health information. There are approximately 40 to 44 million illiterate Americans and 50 million more with low literacy, or about 1/5 of the population, and these numbers are expected to rise. This may be due to a rise in immigrants, aging population, increased complexity of information, and sophistication of technology, and increased numbers of people living in poverty. Changes in policy and funding for education and disparities between minorities and non-minorities further fuel illiteracy. Populations at risk are the economically disadvantaged, older adults, immigrants, and those with English as a second language, racial minorities, and high school dropouts. The unemployed, prisoners, inner-city and rural individuals, those with poor health, and those on Medicaid are also at increased risk. Illiteracy often carries a stigma that causes shame, fear, and low self-esteem, so it is important that patients feel safe in revealing this, and the clinician should be aware of myths and stereotypes that interfere with this process. Most individuals that are illiterate have average or above average IQs and go to great lengths to conceal their illiteracy so they can't readily be spotted. Level of education does not necessarily transmit to reading level. People who are illiterate come from all walks of life, and the majority are white, native-born Americans. Hiding illiteracy is common, and the clinician should look for signs such as avoiding or withdrawing from complex learning situations, making excuses to avoid reading instructions, claiming to forget their glasses, surrounding themselves with books and papers, insisting on reading at home or with someone else present, or asking someone to read for them, getting nervous or acting confused when approached about reading, signs of frustration when trying to read, difficulty following directions, not asking questions or trying to memorize information by watching or listening, and turning in incomplete or ineligible forms. Illiteracy can affect motivation and compliance by making it difficult to analyze instructions, take in and organize information, and come up with questions. Cultural illiteracy can lead to misunderstanding nuance, slang, and sarcasm. Non-compliant behavior may be due to not understanding what is expected rather than unwillingness to comply. Ethical, financial, and legal considerations include Joint Commission requirements that patient and their significant others be provided understandable information in terms they can understand. Informed consent must be the result of understanding benefits and risks of treatment in verbal and/or written form, and there is a liability if patients are given information at a level greater than their ability to understand. Early discharges decrease reimbursement, increased delivery of care in alternative settings, greater demands on clinician time, increased technology and complexity, and assumption that written material is adequate are trends requiring greater patient education. Printed education materials, PEMs, are often written at the 10th to 12th grade level, while most adults read at the 8th grade level. Therefore, tools to test readability are useful when developing written educational materials. These tools evaluate readability by using the average length of sentences and the number of multisyllabic words and are highly reliable and predictive. Computerized evaluations are quick and easy. Readability tools include, number 1, Flesch-Kincaid formula that measures written material between 5th grade and college level. 2, Fogg index that measures material written between 4th grade and college level. 3, Fry readability graph that measures written material between 1st grade and college level. 4, Smog formula that measures between 4th grade and college and is the most popular due to its accuracy, speed, and simplicity. Comprehension tests include closed procedure that is specifically for health literature and the listening test where the clinician reads a passage and the listener is asked questions on key points. Reading skill tests are the RET, Wide Range Achievement Test, and the REALM, Rapid Estimate of Adult Literacy in Medicine, which measure reading and pronunciation of medical terms. The TOEFL, Test for Functional Health Literacy in Adults, NVS, Newest Vital Sign, eHILS, eHealth Literacy Scale, LAD, Literacy Assessment for Diabetes, and lastly, the SAM, Instrument for Suitability Assessment of Materials. Before designing written information, make sure you decide what you want the patient to know, use other forms of media to reinforce, organize topics sequentially, and write 2 to 4 grade levels below the average of your intended audience. Printed materials should use the terms you or your, use short words, spell out words, organize information in chunks, keep sentences short, define unfamiliar words, and avoid using numbers or statistics if possible. Use words consistently and avoid should or other judgment words. Limit characters to 30 to 40 per line and allow plenty of white space. Use color to emphasize key points and create a simple cover page. Keep the document short and with simple font style. Select non-glossy paper and create a summary with bullet points. And lastly, determine readability by using one of the readability measurement tools and document this for future reference. To promote health literacy, teach one step at a time and use multiple methods such as pictures, lists, audio tapes, etc. Keep amount of information small and establish rapport and trust. Lastly, reinforce health literacy by allowing the patient to restate the information in their own words or demonstrate their knowledge, use praise and rewards, and use repetition and cueing to prompt and remind the patient of routine tasks. In summary, the ability of learning from instructional material depends on the patient's ability to read and comprehend, in addition to their motivation. Literacy has an important role in this ability. Clinicians should assess the client's literacy and choose the appropriate techniques to enforce healthcare education and understanding.